morning, everyone, and welcome to today's webinar presentation, Trauma and Violence-Informed Public Health Practice, Language Matters. My name is Sarah Carsley. I'm an Applied Public Health Science Specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. Before we begin with today's presentation, I'd like to acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I'm in Toronto on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty is signed with multiple Mississaugas and Chippewa bands. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys and worldviews. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. Lastly, I'd like to acknowledge Daniel Coles, who helped co-author this land acknowledgement, and thank him for sharing it with us. I'll now mention a few housekeeping items. To enhance the presentation experience, participant audiovisual has been disabled. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today's session, Dr. Karen Campbell. Dr. Campbell is an assistant professor at York University in the School of Nursing and has extensive clinical experience as a public health nurse with experience working in the Healthy Babies, Healthy Children program, breastfeeding services, and the Canada Prenatal Nutrition program. Her doctoral research supported an evaluation of the Nurse-Family Partnership program in British Columbia. She is currently a researcher for iHeal, a community health nursing program for women who have experienced intimate partner violence. Welcome, Karen, and over to you.
Thank you, Sarah. I'm thrilled to be here today, co-moderating with you and representing the work of PHN Prep and our team in supporting PHNs and supervisors and managers, home visiting staff, and the work that they do with families. I think today's presentation is going to be incredibly helpful for that. And it's going to focus on the shifts in language and practice that can powerfully improve the care and the organizational conditions that can support equity. And it's my pleasure today to introduce one of my favorite Canadian nurses, Dr. Colleen Varcoe. Colleen Varcoe is a professor emeritus at University of British Columbia School of Nursing. Her clinical background is in emergency and critical care. Her work aims to decrease inequity and violence, including interpersonal and structural forms of violence, such as racism and stigma related to poverty and substance use. Her research includes studies of risks for and health effects of violence and promoting health for women who experience violence, especially Indigenous women, and promoting equity-oriented healthcare at the organizational level. Over to you, Colleen.
Good morning, everyone. Good afternoon if you're somewhere other than what's now called Canada. I'm Colleen Varcoe, and my pronouns are she and her. And I'm really delighted to be with you, and thank you to the Public Health Nursing Group, the RN Prep, and the and Public Health Ontario for inviting me. First of all, I would love to tell you that I'm coming to you from the unceded territory of the Shishak people. And in the chat, I was wondering if you could, if you felt like it, just put a few words about what doing a land acknowledgement, when you do a land acknowledgement, what it means to you. I keep trying not to make mine rote. I want to make it sincere and meaningful and live by it. And for me, the fact that I have always lived on Indigenous territories means that, and have benefited from the consequences of colonialism, means that I am in service to Indigenous people. Basically, that's what I take from it. So please feel free to do that. I was invited to talk with you folks today. First of all, the invitation was to talk about words and how words matter, in part because in my program of research, we've continuously tried to develop tools and resources for people, not just in practice, but leaders, educators, and so on in healthcare. And we developed this little set of pocket cards just in response to a physician who was responsible for the residents in our Northern Medical Program, who was having real difficulty supporting residents to speak to people in ways that were really respectful and non-stigmatizing and so on. And so we sat down with her and she said, well, they say this, but I really want them to say that. So we developed these cards, and it wasn't a systematic kind of approach. It was just more some of the challenges that she had been running into. So what I would like to do is, rather than just talk about words, like to talk to you about language. And rather than just trying to give you some recipes of say this, don't say that, really dig into some principles that I'm hoping you'll take away to use in your own context, with your own position, your own positionality, your own role. Because how I would say things is not the same as how you would do it. So I'd like to sort of look at the principles of trauma and violence-informed care and suggest to you that whereas we often stay really focused on the intrapersonal between, provider and client, we're going to get more traction by looking inward at our own biases, our own thoughts, and outward at the context in which we work. And that's going to really inform how we work with people we're trying to serve. So I'm hoping that through this, that you'll come up with some strategies that suit your own practice and your own setting and role. And because I know many of you will be in leadership roles or you'll be educators, I'm hoping that there are some of the tools that I'm going to point you to that you might find useful, and you can see ways that you could take action toward more trauma and violence informed approaches within our healthcare system. So those are my goals, and I just wanted to tell you a bit about the background that I'm drawing on. I started out doing research in the area of violence against women, and specifically the nursing response to violence against women, and then quickly ran into a wall of racism and discrimination, anti-woman sentiment, classism. So I had to really look at structural violence and how it impacts on folks, and combine forces with other researchers to look at how is this done well. How are organizations, and we studied in Indigenous context, serving people who experience high levels of structural violence in ways that are really effective. And from that, we developed this, what we call the dimensions of equity-oriented care, and then turned it into an intervention so that we could better support healthcare providers and organizations to provide that kind of care. And we tested it out in 2 primary care clinics in BC and 2 in Ontario. And then we've just finished a fairly big study doing a similar kind of approach in emergency departments. And all throughout, we've been working on providing tools to make this so, and gathering them up into an action kit, and that's all publicly available. The last 2 years, we spent really intensively improving our work with respect to substance use and substance use stigma. So these are the key dimensions of equity-oriented care as we kind of currently see them, and the strategies that we have seen are really effective. And of course, because we're talking about trauma and violence-informed care, that's one of the key dimensions. But we think that you can't have trauma and violence-informed care without having an anti-racism lens on promoting cultural safety. And we think that that intersects with a substance use, a health approach to harm reduction. So that's kind of the basis for a lot of the intervention work that we've done. So I want to say a few things about those key dimensions, and especially trauma and violence informed care. I've been sort of pushing on this idea of adding V to trauma informed practice, because I think saying violence and putting violence in the foreground really builds on trauma informed practice to draw attention to the fact that trauma isn't always in the past. It's not just in people's heads. Often violence is ongoing. Also, most importantly for me, it draws attention to structural violence, how we organize the world in ways that really does harm to people. So I think that this idea of trauma and violence informed is absolutely crucial. Keeps our eyes on what's going on for people right now, helps us to better normalize people's responses to trauma and violence, and provides us a bit of a platform for more compassionate and more equitable care. As I said, I would really like to focus on not just words, but all language. Obviously body language. And as you're looking at this picture, I'm inviting you to imagine, what are these people saying to each other? What are their intentions toward each other? But beyond body language, all our language, the signage that people encounter in our settings, the forms, what we're guided to say to people, all of our verbiage and wherever it shows up. And so I'm going to sort of focus broadly, not just on how people interact, but how we think internally, and then how that shows, and then how our contexts are shaping all of our interactions and the experiences of people that we're supposed to be serving. So a really important question that I would like to offer you is thinking about how you want to be read, how you want your organization to be read, and inviting you to invite the students that you work with or your colleagues to think about how they want to be read. Nurses are very effective because the workloads get more and more difficult, more and more challenging. We're very good at being read as being busy, and that's purposeful. We have to communicate we're busy because I can't deal with you right now. Is that how we want to be read? So I am drawing on work that I've done with Dr. Gwyneth Doan, and really trying to have an approach to nursing practice, at least, that is based in complexity theory, that goes beyond the interpersonal relationships and asks us to look contextually at the worlds we're working in, and at our own intrapersonal work. So I just wanted to mention that. And I think that this is really crucial to thinking about enacting trauma and violence informed care. It's not just the person in front of you and the trauma that they may have experienced in the past or what they're going through currently. It's the context that you're working in that shapes the possibilities of a trauma and violence informed approach. And it's also your own experiences, your own history, your own biases, and so on. And so what we've been trying to get folks to do is look at all the interconnections and be much more sort of intentional in how we interact. So just inviting you again to pause for a moment and have a look at this visual, and what comes to your mind? When you think about trauma and this picture, what are you thinking about? If you think about violence, if you think about, for example, racism, or you think about power, what's coming to your mind? What do you think is going on within each of the individuals that you see in the foreground, the people in the background? Do you think the police officer would behave differently if he were in a different setting, he was in an affluent neighborhood, or if there are fewer people or more people around, what would change? So just an exemplar of how influenced we are in all of our interactions. So we're coached to think about violence in certain ways. So if we're thinking about trauma and violence informed care, I think it's really crucial that we focus on how we think about violence. How are we constantly being schooled to think about violence in a certain way? And I show you this picture of my mother and my stepfather because this was one of the first areas that I had to do a lot of work on my own biases, because the world told me, and my close circle told me, that my mother should have protected me from my stepfather. And so I understood that if I was going to work with women who were experiencing violence, which is what I was doing, I really had to focus on getting rid of and pushing back against those biases that were coming at me all the time. So each of us has to sort of look at our own, what's shaping our own thinking, identify our own hotspots, as I call them, and then work against those because they're constant. We're offered words and ideas and discourses continuously that shape our thinking. Similarly, if we're going to promote cultural safety, we have to really think about how we're thinking about the idea of race. We're constantly, even though we can say, well, race is a social construction, racism is a real thing, we're constantly encouraged to think about race as though it's a real biological thing. We're offered forms that say, what is your race? Well, human. We're not offered that option. So how are you schooled to think about race? And then, and this is really important, I think, for your thinking today, is how are we taught to think about substance use? And we've got three sort of different tropes coming at us all the time. The first, and they all coexist, but we started out with understanding substance use or overuse or heavy use, as I prefer to say, as a moral failing, and that's still alive and well. That we think of folks whose lives are impacted by heavy substance use as morally weak or inferior, and that's been supplanted largely by the disease model, the biomedical model, thinking of substance use that's harmful as a disease. And that really dominates right now. But I'm hoping that the newer thinking around substance use as learned behavior, which is also sort of gaining traction, I'm hoping that that will sort of more fully inform our work in healthcare. So I just want to briefly go through each of the principles of trauma and violence informed care that our group has put forward, and think about language and think about how we engage with people. So we have this idea of identifying red flags, but how are those communicated to you? What exactly is it that you're looking for? What do you think of when we think of red flags? And I'm questioning that because I think pretty much anything can be a red flag. When we talk about children who experienced maltreatment, we entertain both ends. Children who are very, very withdrawn and quiet, or children who are very aggressive and outgoing. So I think we need to think about what exactly it is that we're looking for. When you're responding to people, when you're responding, for example, to disclosures, we advise the kind of the lives approach from the World Health Organization. But how do you actually do that? How do you personally convey that you believe a person, or how do you validate somebody? So I might say, oh man, that must have been awful. Or I might say, no one deserves that. But my language and your language is not going to be the same because we're all positioned quite uniquely. So just thinking about that, what would you do to strengthen your ability to enact this? And I don't want to skip over the fact that we constantly need to be working in cultures that are striving to be culturally safe and trauma and violence informed, because the language that you use and your interactions can be very intentionally trauma and violence informed. But if you're not working with coworkers and within policies that make that feasible, it's really a struggle. So how do these things happen, and how do you use your language to convey that you are trustworthy or that your organization is trustworthy? We often expect people we serve to trust us, but it's incumbent on us to be conveying that we are trustworthy. So how do you do that? And then what are the policies in our organizations that make it possible? And you folks named harm reduction as maybe the area that could do with the most improvement in your settings. What is it that facilitates that in your organization? What are the policies? Do you have a zero tolerance for use policy? Do people get kicked out of your programs if they're using substances heavily? How do you actually provide opportunities for choice and respect the agency of people? What is the language that would do that? And I'm going to offer you some examples of that. And then finally, how do we actually use a strengths-based approach? Because a lot of our healthcare practices are predicated on us being the experts and clients or patients or people we serve being in deficit. So let's just sort of talk about the language we use. And I think that enacting these principles, it's useful to focus on some of the narratives that we're constantly facing that are coming at us, and identifying those narratives and then shifting away from them. So anything that is deficit-based, problem-based, is going to mitigate against your efforts to be strengths and capacity building. Anything that blames the victim. If you talk about vulnerable people or at-risk youth or whatever, that it's locating the problem in the individual. So it's not intentional that we're blaming. Often those words are used in a well-intentioned way, but has a very negative impact on people when they wear those labels. Anything that focuses on people's choices that's decontextualized from the circumstances of their lives. Anything that, in our work on women experiencing violence, the trope is still available. Why doesn't she just leave? As if that's a simple choice. Anything, obviously, that's stigmatizing, stereotyping, talks down to people, is paternalizing. When we use our patients, or we say, we are going to do this, that, or the other. Anything that pathologizes people. And I put the picture of the pregnant woman smoking because that was, for me, the place where I had to do the most work on all of these things. I was a very intolerant ex-smoker. So I want to acknowledge my colleague, Dr. Susan Jack, who's not here today, but she's been gathering up principles toward trauma and violence informed care for years, and this is her slide of some examples of those. So she's sort of continuously gathering the problematic areas that she runs into and offering alternatives. So the what works in your area might be quite different, but just to give you some examples of language that is problematic and how we can shift away from it. And I think the first step is always identifying when things are difficult. And just to give another example, my colleague Dr. Petria, who's at the University of Northern BC, of New Brunswick, Dr. Petria Taylor, has been also working on changing deficit-based blame the victims narratives. And so she just offers the example of these kinds of things where people are thought to be being dramatic. They're seeking attention, they're drug seeking, whatever, rather than shifting to understanding that many people have histories and are experiencing ongoing violence, and there's always a reason for however people are behaving. So, as I said, I really want to focus on the fact that it's not just the words that we say, but all of our language wherever it appears. This is from my collection of what I call my welcome signs. And as you can see, they're not very welcoming. And behind those are a set of narratives and assumptions about our relationships with patients and who's in charge. So, you know, often folks say to me, well, we're required to put those up. And you may be required to put those up, but you could also put up bigger, more welcoming signs. So it's not just in our signage, but in everything that we do and in our policies. And my colleague, Dr. Helen Brown, studied neonatal nursing practices and women's experiences of having a baby in the neonatal ICU. And those women, all of those women, and these were predominantly women who are newcomers to Canada, it just so happened, really got the messages that they were inadequate, that they didn't know what they were doing. And it was through the nurses being very efficient, but also they experienced disrespect of their babies. And this was really incredibly undermining the efficiency and detachment of the nurses, even though they weren't directly necessarily even interacting with the women who were mothers, was really profoundly distressing for the women, really undermined their ability to become good mothers, especially to neonates. But I want to turn to an opposite example. I have the privilege of being a founding member of the board of Kilala Laylam, which is a Indigenous-led primary healthcare clinic in the downtown east side of Vancouver. And at Kilala Laylam, we don't call the people who come for service patients or clients. We call them members. They're members of the co-op. They have to pay $1 to become members, but if they don't have $1, somebody will lend them $1. And you would not believe the profound impact of that simple change of folks feeling like they're members, everyone referring to people as members. And it doesn't just affect the patients or the members and or the staff, but also all of the other organizations that staff and the folks who come for treatment and care and so on interact with. Even what we call our programs can be profoundly impactful. And I just never forgot the public health nurses in Fraser Health Authority were shifted from doing more of a universal home visiting program to all mothers, new mothers, to a program that was focused on marginalized women. And they were very distressed because they said that women didn't want them to come anymore because it made them stand out in a really problematic way in their neighborhoods. So to help you do that, we've got a lot of resources. So I know you're really thinking about language, and language is throughout all of this. And we've tried to put together a lot of tools that will help you do that. Will help you be more trauma and violence informed, and bring your colleagues along with you and your organizations. So these are all available on our Equip website for you to use. But I wanted to point out a couple of specific ones that are really intentionally focused on language that I'm hoping you'll find useful. So the first one I'm going to draw on our suite of resources around harm reduction and substance use health. And this is a opiate treatment agreement. And a nurse practitioner came to us with an agreement. And she said, I know the language is bad. I know that I feel really uncomfortable when I'm using it with the people I'm seeing, but I don't know how to fix it. So we started tracking changes for her, and then we realized that we really were drawing on the trauma and violence informed care principles, and we thought it would be maybe helpful for other people. So just for example, we don't use the word addiction. If somebody wants to call themselves an addict, fine, but we don't use that word because it's been eradicated by the American Psychological Association. But it's still really dominant, and yet we often it's a term that's really overused and very pejorative, very labeling for folks. And there are many harmful effects of substances, including, of course, prescribed drugs, that are beyond the more narrow understanding of addiction. That's just one example. So we're always looking at how in all of our language can we have safer, less stigmatizing language. Also, just you'll see that we've shifted from we are going to adjust your dose to we're going to help you do that. So anything that you can do to acknowledge people's own agency and build that right in will improve the experience for the people you're serving. So this is an example. Again, it's on our website if you're interested in it, interested in looking at more detail, because I think it helps surface some of the principles that we can use, not just in our, in our documents, but in all of our language use. So we've also got a lot of resources around trauma and violence informed care. And I'm just going to, again, show you one of those that is an example of something that I think you can use, particularly with your organizations. And it's designed to, it's called Rate Your Organization, sort of like you did in your own mind, but with more detail around what is required to be trauma and violence informed. And it's intended to be a discussion tool, not really a rating scale where you hold up judgment to yourselves, but really a conversation among people about where do we need to put our attention. So it just invites folks to rate on all the different strategies that you need to use to have an organization that's trauma and violence informed, and to support individual providers to do that more effectively. And then it helps you zero in on where could you make the greatest changes. And Dr. Campbell and I were working with a group of nurses just a few days ago, and I was kind of surprised that what they really focused on as the weakest was this idea of how place and space is used to make people feel safe and welcome and emotionally safe, physically safe, and so on. So anyway, it'd be you're welcome to use it within your own organization and really see where you might impact through your language, through your signage, and to be more trauma and violence informed, to create safer spaces and so on. So the picture I showed you at the outset was located in St. Paul's Emergency Department, where we most recently did our intervention work. And I wanted to show you the after picture. We supported the staff to make the changes that they thought were needed, and they wanted to make their space, their waiting area, more welcoming and inviting to people, particularly to Indigenous people that are served there. And it wasn't just a matter of slapping some Indigenous art up on the wall, but rather a matter of making relationships and really partnering with their Indigenous health team, with local Indigenous communities, and then having a ceremony. And it wasn't just the individuals that were involved, it was everybody. And I hope you can see the amazing transformation that they accomplished. So in summary, I just wanted to kind of recap. I think that there are things that you can do, that individual providers can do, particularly in their one-to-one interactions. But what we do within our own selves to make sure that our biases are eradicated so that they don't show, that they aren't read because they don't exist, is far more important. And what what we do in our organizations, the policies and how we enact them. So if people are feeling uncomfortable with a given practice or policy, that's where I would be looking to see what is the language that's being used, what's the narrative behind the sign, and where can we make changes. So trauma and violence informed care isn't just focusing on things related directly and obviously to violence, but anything related to the idea of race and racism, or poverty or substance use, and other things as well, that I'm sure that you can name, ability, for example. And I think, over to you, I'm inviting you to think about, is there anything from what I've said that would be useful to you? What can you think of in your organization that would be more supportive of your efforts to be trauma and violence informed and to practice in that way? And are any of these tools useful to you? I'm happy to report that we have Nadine Wathen and I have a edited book coming out with some amazing work by amazing people in it. That's intended to be a handbook for practitioners on implementing trauma and violence informed care. So hopefully there'll be something useful for you in that as well. And I'm going to toss it back to Dr. Karen Campbell.
Thank you so much for that, Colleen. It's always such a pleasure, and I always learn so much whenever I work with you and learn from you. And listen to you. So we're going to move into the question and answer segment. I'm going to encourage everybody, all the participants, if you have questions, please pop them into the question and answer pod if you haven't already had an opportunity to do so. And there are questions waiting for you. So I think I'm just going to start with the way that they're laid out for me here. But the first question is about, how do you respond to readers or colleagues that use paternalistic or deficit-based language?
Wow, yeah, that's just excellent question. I mean, and it depends on your personal position, your positionality, your level of power within the organization. But I think it's the same as responding to any kind of discriminatory comments. And by the way, we've got a little tool on our website that is about responding to discriminatory comments. And so with caution, because everyone's positioned differently, you can use a range of things. You can say, I'm really trying to not use the possessives, or I'm trying to shift away from. So you're not necessarily just calling a person out. You can model. You can look for opportunities to correct in a tactful manner. So if somebody's, Karen, you and I were working with a very young nurse just this week, and she was really struggling with being at the bedside, and her colleagues referring to a young person who was using a particular substance in a really derogatory way. And she was really struggling because she's quite young, she's junior. How was she supposed to do it? And so we discussed this with her. So I might go in and say, folks, people don't use meth or whatever the substance is for no reason. Or I could go in and I could say, people who use usually or quite often have very, very significant histories of trauma. People who use really heavily. I can correct, or I can say, oh, could we use this word? And it really depends on positionality. So from the question, I'm inferring that the person is referring to somebody who is in a position of authority, and that's the most challenging. Another thing you can do is really get your allies going and bring forward, independent of what that person's doing in that immediate moment of particular behaviors, bring forward some suggestions, some strategies, some language change that's not necessarily directly focusing on what that person is doing, but is indirectly tackling the issue. So, bringing up a set of principles, we're making a strong effort to be more trauma and violence informed. These are some of the principles that we're trying to enact. So we would like to go through all of our language and try and get rid of where we are using possessives, where we're using language like addict or, whatever the problematic language is. I don't know if that helps, Karen.
It helps a lot. And when you mentioned the younger nurse, I think this next generation of nurses that are coming up also have really interesting ways of using language and being aware of things just because of how they've been schooled. And I think it's such a nice opportunity for us to work together with them. Just as you've mentioned, in terms of language, because you mentioned addict, one of the questions here is about BC. And in BC, we have the Ministry of Mental Health and Addiction. If you were to rename that, what might you rename it?
I'd call it the Ministry of Substance Use Health, I think. That was that's the best I can do on the spot. But, we've been trying to, without going away from principles of harm reduction, because those are really important and it is political, really trying to get a bit more normalizing about our approach to substance use. Majority of people in Canada use substances of some type. And I don't think I buy the argument that we don't need any other language other than heavy use. People don't need to get defensive about heavy use. We find that people are comfortable with that. And I think if we could approach, people with, how's your physical health? How's your mental health? How's your substance use health? If we could really enact a harm reduction lens in all our interactions universally, it would make a huge difference. I thought it was very instructive that the American Psychiatric Association, advised against using the term addiction because of the harmful ways in which it's been overused and the detrimental effect it's had on pain management. I had the privilege of sitting on the advisory for the Canadian Task Force on Pain Management, and substance use stigma is it's so harmful against people who are in serious pain. And I think we have to recognize that when people are heavily using substances, they are dealing with pain. And we have this bad habit of separating out physical pain that's legitimate and psychological pain. And yet pain is pain. And we have very ineffective pain management in Canada. And it's compounded by substance use stigma. So this word addiction is making it even worse. And we've set up policies that make it really difficult for physicians to have almost anything in their toolbox now to manage people's pain. So I went off on a little bit of a tangent, but the best I can do is offer a substance use health lens, which my colleagues at the Community Addictions, and they're working on changing their name, Peer Support Association, which is a group of people with lived experience of substance use and substance use stigma. They've really been trying to foreground that idea of substance use health as a way of destigmatizing certain substances and substance use that's heavy.
Excellent. It's incredibly helpful. I think that language even of substance use health is so important for us, and it's going to make some really significant changes in our practice, I believe. The next question is about how do you find the balance between those who may be using services or resources and those that actually need the services and resources?
Mm-hmm. Yeah, I think that need is an interesting word. Often there's a mismatch. There's a need. People don't come for no reason. There is a need. It's just mismatched with the service that's being provided. So I work primarily in and with emergency departments, and there's this misunderstanding that people come to emergency when they're not acute for no reason, and people don't want to go to emergency. It's not really where they want to be. And there's also this popular idea that they come for a sandwich. Well, if they really come for a sandwich, then they're hungry, and that's a very basic human need, right? And so the emergency department isn't the right place to go for a sandwich. Of course it isn't. But if there's nowhere else to get food, or there's nowhere else to simultaneously get food and somewhere warm to stay, and maybe even a lie down for a few minutes, then that's your option. And we have, whittled away at our social safety nets. So I would say that looking for that balance is focusing on the people that you perceive are coming that don't really have a need, especially on the extreme end of that, where, that this is not the service for them, and trying to identify what is the need, and then where are the gaps that need should be being met in. Sometimes people are extremely lonely, just as an example. They come to places for social interaction, and sometimes we can meet people's needs better. Like, so for example, at Kilala Lalem, folks they can come, they can drop in, and they can have some of their very deep social needs met in a very safe way. It's supposed to be a primary care clinic, but would you consider loneliness a basic human issue? I don't know. But they try to better meet the need, but also work with the community to meet those needs more effectively in a more appropriate place with the right personnel. So that's a bit of a long-winded answer, but I would say focusing on what the underlying need is that's not being met, and seeing if it can be met better elsewhere.
Very nice. A few people are asking for the titles of the two books that you mentioned. So I think one was How to Nurse, and
yeah, Relational Inquiry, I think it's called, How to Nurse, yes. And the other one is Trauma and Violence Informed Care, a handbook, I think we called it. And it should be online this month from University of Toronto Press. And I could share those titles, and I don't know if you have a mailing list I could go out to people, I think.
So if you follow PHN Prep on any of the social media platforms, LinkedIn, Twitter, or anywhere else, we can certainly add Colleen's book, How to Nurse, which is already out. It's a great read. And then the new book, we can post that once it comes out as well. Excellent. I think we have time for a couple of more questions, and the names of those books are now in the chat. Regarding the zero tolerance behavioral signs that you mentioned about, that you posted whenever you walk into a place, you mentioned that they're necessary. You also mentioned having larger, friendlier, and you had a reaction. So yeah, tell us about that. And is this what we should be advocating for, or should we be advocating to get rid of these signs? What's your thoughts about that?
I think it's never going to be as simple as taking down a sign, right? Got to have better practices to replace it. I think there are reasons where we have zero tolerance of substance use in certain organizations. We have zero tolerance of violence, and I think the research pretty much shows that that's not getting us where we want to get. So to tackle the zero tolerance, so I don't know if the question's about zero tolerance for substance use or violence, but tackle the substance use first. An organization I've worked in has, or a couple of them actually, have those zero tolerance policies and signs. And so what it means is it drives people to use in the driveway or on the street or whatever. I don't think that's health promoting at all. What we've been advocating is safe supply programs in all of our health facilities so that people can, whatever they're using, can safely access safe supply in any setting. So one community that I most recently worked in, they had that a zero tolerance policy, and they would discharge anybody that was caught using substances. I'm talking about illegal substances or criminalized substances. And so the ambulance attendants in the community were just beside themselves because they had to keep reversing people on the driveway up to the emergency. So folks would get kicked out of the hospital and have to go across the street or use on the driveway. And so the ambulance was constantly being called to come up and reverse people, and people were dying. And you know, that to me seems like very wrong dynamics. The zero tolerance for violence policy, you know, we keep putting up more bars and hiring more security guards. And the most effective anti-violence strategy I ever saw was in a primary care clinic, where instead they hired an Indigenous elder, to be in the waiting room. And wow, just calmed everything down. Oh, and they provided water and coffee for folks. And it made a big change in some of the behaviors that people were exhibiting. And I'm not implying, by the way, that it was all Indigenous people. It just happened to be an Indigenous organization, and that was their solution. So I think that looking at the signs and thinking about how welcoming and how trauma and violence informed they are, and then going deeper and saying, what's the narrative behind that? What are the set of assumptions behind that? And then if we really wanted to create safe spaces for everybody, and I'm not just talking about people who come for service, I'm talking about the staff too, because the levels of violence against staff have gone exponentially up, and it's horrendous for people. So how do we get together and make it safer for everybody? The ideas of trauma and violence informed, and this is partly why I'm arguing that we need policy change and language change throughout the organization, because if we just keep setting up staff to be in opposition to the people they're serving, you know, get them out as quickly as possible, you know, you're being timed, what's the door-to-doctor number, and encouraging people to see those that are coming for care as less deserving or undeserving or inappropriately using services, we just are upping the tension in all of the workplaces. So yeah, look at the signs, but it's not so simple as simply advocating about the sign, but advocating for the thinking behind it and the broad approach that's needed to create the spaces that are trauma and violence informed.
There are so many incredible questions that are here. I wish that I could read them all to you. I wish you had time to answer them all. But you did mention just there about that abuse or violence towards, we're talking about nurses primarily here, but towards staff are real. And one of the questions is about how this approach is really helpful for clinical care. How would you incorporate this into people management when you're dealing with perhaps a colleague that's likely experienced trauma? And I'm going to add to that, and if they've experienced trauma, they may indeed be also experiencing ongoing violence. So do you have any thoughts about working with clients just in the last minute or two?
Clients or colleagues?
Sorry, colleagues.
Yeah, you know, I've never asked a person, never intrusively inquired, but I put myself out there as a person who's a safe person. I try to convey trustworthiness to my colleagues as well. And in all my behaviors, and because people are judging you every rightly so, every minute. And so putting yourself out there as a safe person to talk to, being accepting of people's behavior, acknowledging the circumstances. So one of my favorite moments in and it wasn't with a colleague, but it's something I have done with colleagues, where I was working with a man in downtown east side of Vancouver, and I was talking to him, and I just, kind of a casual build-up conversation. He's from Saskatchewan, and I said, "Oh, how long have you been here?" And he said, "Oh, I've been here since I was 13. I said, "Oh," I said, how 13. I said, "Little boys don't leave the farm for no reason when they're 13. And he said, "Yeah, mine was a baseball bat." And it was just, it was a kind of a turning moment in our relationship. And so I think, without being intrusive, without inquiring, but conveying your understanding of people's histories, your openness, I think is the way to go.
I've got one more quick question. It's not quick at all, but it's so important. And when it's about whenever we have to make reports, a duty to report, and for nurses that are working with expectant mothers, where now the client has said that they are a heavy drinker, how do we discuss this with them without sounding discriminatory or judgmental? And that language that I've heard you use so many times in the last couple of weeks about nobody does this for no reason. That has changed me in so many ways, around using it around smoking, around trauma, around anything. It's just has such a profound effect on me. But how do you approach heavy use with whenever you know that you're going to have to make this mandatory reporting without sounding judgmental?
Right. Wow. Okay. You just give me 1 minute left and ask me the most challenging, profound question, right? So, I mean, collaboration, I'm going to say collaboration, allyship, saying, "Oh man," expressing your concern. We're in a bit of a pickle here. And I just want to say, I'm going to be with you every step of the way. You know that I'm going to be in a difficult position here because I'm going to have to do something. Whatever your language is. I mean, it's got to be your language, not mine. But whatever way you can convey that you are with that person and you're not judging, just say, "Oh, wow, that must be so hard for you. You must be so worried." Like, acknowledge that person and validate them, and assume that they care. It's a really hard spot.
And it's so helpful to listen to even how you frame that, because that's going to help so many of us to identify what our language is and what words we use. So we really appreciate that. Thank you so much for doing this with us today. And as we wrap up this webinar, I would like to thank Dr. Colleen Varco and Dr. Sarah Carsley for co-moderating with me. I'd also like to thank everyone who joined us today for PHO's webinar. And on behalf of the PHN Prep team, we would like to wish all of the nurses a happy Nurses Week. This week, we celebrate the important work that nurses do to support the families that are enrolled in the home visitation programs in Ontario, for the contributions that you make to improve child health, parenting skills, and for all of the family use of services. Next month, we are having another webinar, and it's entitled Warm Referrals, a Trauma and Violence Approach to Supporting Clients' Engagement with Community Services, and that should be open next week.
Yay, go nurses.